Good evening, everybody. We want to thank the people here for joining us, and of course, those of you watching on video. Tonight, we were very fortunate to have one of our colleagues from UK. Markey Cancer, of course, is one of our partners here at TJ Regional. We have Dr. Clark here, who does hers. She's a breast radiologist who does specifically breast imaging. As many of you all know, particularly in the primary care fields, and did some changes in 2024. She's going to elucidate some of that information. And again, particularly the work tonight, I believe Dr. Clark is dense breasts and what the current recommendations are. We appreciate you making the trip and back tomorrow, but thanks for coming.
I appreciate it. All right, thank you. So, hello everybody. I'll be talking today about mammographic breast density, the national standard law that passed in 2024, and what that does for notification and information to the women and the providers. And I'll be talking a bit about supplemental breast screening and how that is important with the new updates in the law. So so no disclosures. So just quickly a little bit of a background and practice gap. So dense breast, what are dense breasts? It's nothing that you feel, you don't see it, it's just it's a descriptor that we identify when a woman gets a mammogram, okay? So we can only tell if a woman has dense breasts or not dense breasts based on the mammogram. And 40% of women have dense breasts, but what that is related to is dense breast is an independent risk factor for breast cancer. Just by virtue of having dense breasts, 40% of the cancers can go undetected when we read these mammograms. So up until September last year, state laws had a lot of inconsistent language when they would send their lay letters to the patients. So some states would inform the women of having dense breasts, some would not. Some would tell them that, hey, this is indeed a risk for breast cancer. Some would not. Some would tell them you need to do something about it, maybe get some supplemental screening. Some would not. So there's a lot of inconsistency, which brought about a lot of patient advocacy when these women were diagnosed with breast cancer following a negative mammogram. So that took off, and eventually in 2024, the FDA updated the final MQSA, which is the Mammographic Quality Standard Act, to create a unified language, to make a final rule on this, to inform women and counsel all patients about their breast density, and that has to be uniform throughout the entire United States. So wherever you are, you're getting the same information, and that will be the same throughout. So the objectives of the study was to define dense breast and define its limitations, to talk about the FDA ruling that updated the MQSA, informing patients and counseling the patients of their breast density, then understand some supplemental screening, and then talk about insurance barriers. So what this FDA ruling again did was to consistently inform all women about their breast and to reduce any confusion or disparities that existed before between various states. Obviously increasing patient education and letting patients know that dense breast is a risk factor for breast cancer. And now you have that information, so talk to your provider about making a decision about supplemental screening, which I will talk about in a bit, and how that identifies additional cancers in addition to mammography. And then the predicted outcome was that FDA would foresee a reduced mortality as well as reduced treatment cost because of this notification law. All right, so we all know, I don't know if you all know, but we all know in the radiology world that screening reduces breast cancer, right? So mortality reduction is quite significant. There are many clinical trials out there that have proved by now that there's about 40 to 50% mortality reduction just by screening mammography alone. But then, while this is laudable, we still have to wonder how come we're not reaching that 100% reduction in breast cancer mortality, okay? So knowing the limitations of screening mammography plays a big part in that. So what we already know as breast imagers is that screening mammogram does not benefit all women equally. So the women that have dense breast tissue will have a disadvantage compared to those that have fatty breast tissue. And I'll show a diagram so you can all see that. So the success of a screening mammogram is really dependent on the breast tissue density. This publication in JAMA from 2022 estimated that almost 260,000 breast cancers went undetected on screening mammogram in the 2021 year, and that was due to dense breast tissue on mammogram. And that's roughly about the same amount of cancers that were detected. So here's that number. We're only detecting 50% of the cancer that we should be detecting. So quickly, just a diagram of what the breast tissue looks like. So the components of the breast tissue are the fibroglandular tissue composed of milk gland and milk ducts in a network of fibrous tissue, so all this pink stuff in here. And then you have this fatty component of the breast that is depicted in yellow. On the mammogram, all the pink stuff absorbs the X-rays and looks white, while the fatty tissue is more penetrant to the X-ray and will look dark or gray for us. So you have the muscle here. Muscle is also very dense, so it will look white on the X-ray. A small cancer will also look white. So white on white is not really easy. There's not enough contrast to detect with accurate certainty at all times. So this provides a limitation in itself. But dense breasts, we're talking about it, dense breasts are normal and dense breasts are common. And 50% of women in their 40s have dense breasts. 40% in their 50s will have dense breasts. And then with aging, as your estrogen and hormone levels drop, about 25% of the women, density will decrease, but 25% of the men will still maintain dense breast tissue. So as you see, majority of women in their 50s will have dense breasts, or prior to their 50s will have dense breasts. So this is what I was talking about when I'm referring to dense breast. When we read a mammogram, we are describing one of these four densities, A, B, C, D. So fatty breast primarily looks dark, very little white stuff, very little fibroglandular density. So if there's a hypothetical cancer here, it's really easy for anybody across the room to see that. When you become scattered, again, still very nice, a lot of fat component, a little bit more fibroglandular tissue, but still we're able to detect that hypothetical cancer quite nicely. As the fibroglandular component grows into the heterogeneously dense and the extremely dense breast, you could see the contrast completely reduces and it becomes harder and harder to detect cancer in what we call the dense breast population, which includes these last two groups. 60% of the screening population falls into this category, which is a non-dense breast, but 40% will fall into this category. And as you saw, majority of this category will be the younger women under age 50. And as you go from fatty to extremely dense breast, that increases the risk of breast cancer. So by two ways, right? One is because these women have more breast tissue, so more real estate for cancer to come out, to grow from. And then secondly, the masking effect. It's really harder to detect, a small little white cancer when the background of tissue is mostly white. So twofold. Density creates a masking effect, and then you have more real estate for cancers to grow. So a lot of these cancers will go undetected in dense breast women, and then we notice what we call interval cancers. So the women that have dense breasts also have higher interval cancers, and that is the cancer that is detected before the next annual mammogram is due. Those are way more common in women with dense breasts, and they make up to 1/3 of the cases of breast cancer diagnosed in women in screening mammography. So when we read a mammogram report in a dense breasted women and we give it a negative or a BI-RADS 2, we call it BI-RADS 1 or BI-RADS 2, what that really means is that no cancer is seen on that mammogram, but it doesn't necessarily mean that the cancer may not be present in there. There are limitations to this exam, and within those limitations, we may potentially be missing cancers. So if you imagine a room full of women, like out of 100 women, 60% who have the non-dense breast will have that advantage where cancer will be detected way earlier because they're fatty. Nice contrast. The 40% of women with dense breasts, however, they may have a cancer mass or go undetected. So this is truly the definition of healthcare disparity, where some people or some fare better than others in healthcare systems and procedures. And this is not entirely random, because as we saw earlier, the younger women are those that are affected the most, because those are the ones with the dense breast. And then certain racial groups, including African American, Asian, and Hispanic women who are more likely to have dense breasts, are the more likely affected by having a cancer miss. So this is definitely ethically troublesome. And this publication from JAMA in 2019, looking back at the last decade in the United States, identified that most breast cancers that were diagnosed were in the younger population, and that was defined as adult under age 50. So what are we doing about it? Well, there's been a lot of research, no clinical trials yet, but a lot of individual research studies have shown that supplemental screening in women with dense breasts who have a negative mammogram provides a lot of benefit. So this study that was designed to look at average risk women and intermediate risk, so these are all women that are not high risk. We already know that high risk women benefit from additional MRI, but these are the women that are of average risk. They looked at this population of women, and through a meta-analysis of 22 studies encompassing 261,000 patients, a little bit more than that. And they found out that about half of those patients who had dense breast had in them identified about 541 cancers that were completely missed on mammography, but that they were detected with supplemental screening methods. And then identified in this big meta-analysis that MRI was a superior screening method. So they looked at a bunch of screening methods, and MRI was the one to identify the most cancers and was capable to detect even the smallest cancer. So with that in mind, I want to show you a case of what I deal with most in my daily practice. So this is a woman, for example, with dense breasts. This is not a screening mammogram. This is a diagnostic mammogram. She came in with a palpable concern in her left breast. This is right, this is left. Triangular marker there demarcates the area. Well, she fills the area of palpable concern. So here's her little cancer. This might not be as difficult to detect because the density of this cancer here is a bit greater than the rest of her fibroglandular tissue. So this does stand out regardless of her dense breast, and it's, sizable. But when you do her MRI, when she went on to do her MRI, the extent of her cancer is way greater than we could perceive on the mammogram alone. And not only that, the right breast, which was red negative, was indeed involved with cancer as well. So this is like opening a window into the dense breast and identifying way more than we can see with mammogram. All right, so the new FDA rule on the dense breast reporting standard. Prior to the rule taking effect in September 2024, about 38 states had various level of notification for women. And currently, now that the rule is in effect, all patients are receiving the same information. And what we're telling the patients now is that either you have dense breast or you have non-dense breast. We're also telling everybody or every woman that dense breast makes it harder to find cancer if they have dense breast on a mammogram, and that it increases the risk of developing cancer. So they are all getting the same information, whether dense or not dense, but the dense women are also getting the information that they would require supplemental screening, and I'll show you the exact FDA verbiage. So the additional information that the dense breast women is this one here below, where they're being told that imaging tests other than mammogram may help find cancers. So this is the exact verbiage that we're using in our lay letters to the patients these days. So if you're not dense, you see this information, and if you're dense, this additional part is added where it says, in some people with dense tissue, other tests in addition to mammogram may help find cancers. This is all uniform now across the entire United States and has increased the supplemental screening tremendously in the clinic, though there are several pitfalls that we're dealing with right now because not every dense woman is able to get an MRI or a supplemental screening. But let's go back for just 1 second to realize how many cancers we are missing using the gold standard of interval cancer. So looking at the women that before they make it to the next scheduled annual mammogram come in with a diagnostic issue, come in with a palpable concern or bleeding, dimple discharge, whatever it may be. So using this interval cancers as the gold standard, we are missing about 25% if a woman is heterogeneously dense, if she has heterogeneously dense breast, which is a category C. And if she is extremely dense, which is that last category D, we're missing almost 40% in women, 40% of cancers. And that's not including, and this is just for the special category of dense breast. And if one takes into account all the visible cancers that would be seen on MRI, sensitivity of mammography is not that great. So it drops to about 30 to 35% in all categories. Just to put in perspective, the risk of having extremely dense breast is about 4 to 6 folds higher than if you were to have fatty breasts, and then 2 folds higher when compared to fibroglandular tissue, which is almost comparable to a 2-fold risk if you have a first-degree relative, like a mother or a sister with breast cancer, or 2 second-degree relatives typically diagnosed before the age of 50. So increasing awareness among patients and providers about the mammography limitations is what a lot of breast radiologists are doing these days to enhance cancer detection through supplemental screening, which has been significantly expanded, particularly since the new rule came into effect. So risk assessment is still not standard. This is still an issue because the current guidelines expand supplemental screening. However, they do not provide a formal tool to use as a risk assessment. As breast imagers, we prefer the Tyrer-Cuzick, but there are several models that can be used, primarily based on family history. Tyrer-Cuzick, the reason why we use it is because it also includes the mammographic breast density. So by using it, we're able to provide a fairly reasonable risk. Even with that, though, we're still missing about 70% or 30% of women that could have benefited from supplemental screening, and that's the most recent I read on it. So it's not perfect, and we're hoping that with the AI and the radionomics, we're able to do better in the future. GALE is not a risk model that should be used for MRI recommendation. It's rather for chemoprevention. Unfortunately, this is still being used at UK today. All right, so these are the updated ACR supplemental screening guidelines, including the dense breast. And these were updated by the American College of Radiology in 2023. And I want to focus just on this part here, talking about the dense breast tissue. So before, in 2018, and the most recent 2023. So as you see here, the difference that's highlighted in red from this paper by Deborah Montesiolo, for women with dense breasts, they recommend annual mammography. DBT is tomosynthesis. So with or without tomosynthesis, though 90% of facilities in the US all use tomosynthesis. But they say annual MRI is a recommendation for these women with dense breast. And they say consider contrast-enhanced mammography or ultrasound as an alternative to MRI, if there are contraindications to using MRI, like claustrophobia, or if there is an implantable device that cannot be MRI compatible. The other addition that I think is really noteworthy is American College of Radiology recommends risk assessment by age 25 for all women. Breast cancer is no longer a geriatric disease. We're seeing more and more young women being affected with breast cancer. I just had a patient that was 26-year-old and pregnant, diagnosed just last week. So it's, I think this recommendation is also great. And this changed from 2018 recommendations, which recommended risk assessment at age 30. The way this could be used is, if you identify a patient early, then screening would start with MRI by age of 25, and then addition of supplemental mammogram by age 30. So MRI, I've been talking about MRI is great. The reason why it's great is because it detects the most cancers per 1,000 in addition to the mammogram. So if we're able to detect about 6 cancers per 1,000 people screened, MRI would, in its first round, would detect an additional 10 to 20 more per 1,000. So that's a great detection, but it does come with the cost of a false positive increase of 9% at that first round. But as you see here, it drops significantly once we have that baseline MRI. The false positive rate will drop down to 2%. And such is the case with ultrasound and contrast-enhanced mammography. However, the difference is that they don't detect as many cancers, though contrast-enhanced mammography is almost comparable to MRI. And that's a great alternative where MRI is not easily accessible or affordable. Contrast-enhanced mammography would be the next recommended modality for supplemental screening. Again, false positives are high at the first round, but once that baseline is established, the false positive rate will drop to 2%, which is reasonable. All right, so we've talked about breast density, but insurance is not uniform. So now that we have this breast density notification law and we're telling women, you have your dense breast, you got to do something about it, insurance coverage is definitely an issue. The Find It Early Act was a bill that was introduced in 2022 in Congress by Representatives Rosa DeLauro and Fitzpatrick. It's a bipartisan bill, but it died quickly. It's a very expensive bill. It was reintroduced again in October 2024. And if this bill passes, it will address insurance barriers to where there will be no out-of-cost pockets for women requiring supplemental screening when they have dense breasts or are at higher risk. So this will be what the breast community is fighting currently to make sure that this bill goes through, though I think it's a very costly bill. And so we're hopeful. It's just the near future may not be, it might be in the distant future rather than in the near future. So yeah, this is an excerpt from the bill. Coverage with no cost sharing for additional breast screening for certain individuals at higher risk for breast cancer. And here it includes heterogeneously dense or extremely dense breast tissue. So this would be a complete game changer if it were to pass. So this is a great website that I hope everybody can visit, densebreastinfo.org. This is by one of the pioneers in breast imaging, Dr. Wendy Berg and her team. But this is the map of the states and the insurance laws by state and what they're able to cover regarding supplemental screening. And up until last year, Kentucky was not highlighted. It was one of these states that do not have color, so did not have any expanded coverage for supplemental screening or diagnostic exams. But as of last year, there was a bill, House Bill 115 that passed that does provide supplemental screening coverage with some caveats. So currently 27 states have laws, and DC have laws to cover some level of additional breast imaging. However, there are insurance plans that do not have to follow the state law. So for example, if you have private insurance, or if you have out-of-state insurance, or if you have federal, like Medicare, TRICARE, and VHA, those are not covered. Again, Kentucky, this is from the densebreastinfo.org. Kentucky passed the supplemental screening House Bill 115, effective January 1st, 2025, where they shall not impose cost sharing requirements for diagnostic breast examination or supplemental breast screening to include but not limited to MRI or ultrasound. Again, there is this caveat: out-of-state, federal, and employer insurance plans that are self-funded do not generally have to comply with the state insurance law. So everybody should probably check with their insurance before ordering or before getting the MRI, because there are still very many people who think that they may be covered but may not qualify for it. So this is House Bill 115. I think this was a great addition to the many states who already have the law that covers supplemental coverage. So this is the actual letter that the patient will see with the language about the new federal requirements on the breast density. So here is the federal requirement language verbatim on this patient with dense breast. And Kentucky state law also requires us to place our specific state law notification, which I think Kentucky was ahead of many states before this law passed. So we did have a language here that was appropriate. The only thing that we did, I think still needs to change, is that it says here, at this time, there is no specific recommendation for additional screening or other measurements to having dense breast tissue. This is conflicting language when it's placed next to the federal law requirement, and when you compare it to the American College of Radiology new guidelines, actually clearly stating dense breast tissue recommendation for supplemental screening MRI. So I think eventually this will be omitted, but currently this is the present state. So I really find it confusing for a woman to see both this and this in one place. And most of the information is congruent, but this part here where it says there's no specific recommendation, it's a bit misleading. So I think this is where the healthcare provider reviewing this information with a patient would be very helpful, and having a discussion openly and making the decision as a shared decision. So why it matters to have breast density knowledge and early detection, because we know that there is a cure for breast cancer if it is found early. So 5-year survival at 99%. And then at later stages, that drops significantly to less than 30%. It is important to educate not only the women, but also the providers so they can discuss the role of supplemental screening. And more of us breast radiologists are becoming more proactive in providing lectures and educating providers about the role of supplemental screening in early cancer detection. Obviously, a woman should never have to choose. So insurance coverage is super important. She should never have to choose about necessities and getting the right breast imaging for early detection. Well, that was faster than I thought. All right, so the take-home points: the density-informed law is thankfully now uniform across the United States. Expanded breast imaging insurance laws are currently state-dependent, so we're still fighting to get a national law passed. There is a new national standard notification law. Breast imaging radiologists and centers should really be more proactive in talking to patients and getting prepared to support this influx of extra supplemental screening that will come, that is coming with it. And obviously this federal insurance law, it will be a game changer once it comes into effect and hopefully it passes. So that's that.
Dr. Clark, my question would be is, if we focused on the very highest risk with dense breast tissue, is the current recommendation to mammogram those patients and then move to supplemental, or do you just do that the first time and then continue MR from that time forward?
So the current recommendation is if you are identified as a dense breast, whether you are heterogeneously dense or extremely dense, you get your mammogram. And right now, when I look at your mammogram and I see no other risk factors, I'm not particularly obliged to recommend an MRI, but the letter will say, you have dense breast, you are at an increased risk for breast cancer. Talk to your provider about supplemental screening. So they are taking that burden, I guess, from the radiologist and placing it more so on the provider to have the discussion to make a shared decision with the patient. And so if the patient decides to have that MRI or to have that supplemental ultrasound, they can have it at the same time when they come for their annual mammogram. But the recommendation is there's a bit more benefit if you stagger it every 6 months. So you get the MRI, or you get a mammogram, and then you get an MRI 6 months later, then you stagger both of them every 6 months. And there is no true, hard stop. You continue until you are in good health. But from what I hear in my society, and this is not a determined rule, is that after the age 75, you can have an open conversation as to the frequency of the MRIs following that age. Or mammogram should continue indefinitely, not indefinitely, until you're in good health. So you could I've seen people have a mammogram at age 94. So you're wondering why is she still having a mammogram,
This might be a little too into the weeds. My question, just as a scientist, would be, if I mammogram these dense breasts, just focusing on the high-risk group, do I know what the number needed to examine is based on just the mammogram to find a cancer versus the MR? Do we have a number needed to evaluate, number needed to treat, basically? Like how many mammograms should we have to find abnormal for dense breast? How many MRs would we need?
So the cancer detection rate, I think that's what you're asking. So the cancer detection rate for a mammogram is about 6 per 1,000. Okay. So I would have to read 1,000 mammograms to detect 6 cancers, and that's our national standard. What we're saying is there's a lot of cancers I could be missing in this 1,000 mammograms. If I add an MRI, I could be detecting 26 cancers per 1,000. So there is a 20 patients that I missed on mammograms that I could be detecting with MRI. Now, when I read a mammogram and I see at least one risk factor, if I see this patient had, I don't know, a mother with breast cancer, I will recommend an MRI. Or if I see that she had a biopsy that was high risk, I will recommend an MRI. I'm very alert as to any family history, like even if it's a single factor that might bump her risk up, because twofold risk or sixfold risk of breast cancer if you're extremely dense. Then you add a first degree relative, you're already above the 20% high risk lifetime. So a lot of us are doing that, and I think there's a good response from the patients, and we're seeing, higher cancer detection rate. Obviously it comes with a false positive, but once we have that baseline MRI, that false positive rate will drop significantly, and I think it's of great benefit.
And insurance is picking that up in Kentucky, outside of the outliers?
Except for the private insurance, except for federal insurance, except for out-of-state insurance. They just passed the law, so we're part of those 38 states now who have supplemental coverage. And I actually noticed it in my own MRI. My bill dropped significantly between last year's MRI and this year. So last year I paid like $3,000 out of pocket, and I thought, this is insane. Nobody can afford this. That was a lot for me. And then this year my MRI bill was $700. I was like, I don't know what changed. So I think something is happening.
I have two basic questions for you. One is, what is the reason dense breast tissue has a high incidence of cancer itself?
There's more fibroglandular components. It's kind of like more real estate for cancer to grow from. It's like if you have more glands, those ducts and the inner lining of the ducts. If you have more ducts, the inner lining of the duct will go metaplastic, will go anaplastic, and then will eventually convert to cancer. If you have more ducts and more glands, you're prone to developing more cancer just by virtue of where it all starts. It starts in the ducts and in the glands. So if you don't have as much ducts and glands and you have more fatty component, then you're just less likely to develop it.
In particular, what kind of cancer do you find in dense breast tissue?
There's not one specific cancer. Well, largely it's invasive ductal carcinoma. That comprises 70% of breast cancers we identify. Then there's invasive lobular carcinoma, which the current thinking is that it develops in the lobules. So ductal is 70%, lobular is 30%, and that's the current numbers. So some is changing on that, but.
So second question is, the incidence of breast cancer now is more in younger population. Mm-hmm. So what is the reason behind that?
That's a great reason. I probably win a Nobel Prize if I knew the answer to that. I don't know. I think there's a lot of multifactorial components that come into it. Genetics plays a small part. Only 10% of breast cancers is genetics related. So there is, they say there's diet involvement, there's alcohol involvement, there's lifestyle, there's hormonal exposure. There's other factors that are socioeconomic factors that, can be associated, but it's a multifactorial disease, and I don't know that I have a specific answer for you. But we know that incidence of breast cancer the prevalence of breast cancer is increasing. It used to be 1 in 8 women, and 1 in 8 women translates to about 12.3%, which is what the average risk for the population is. And currently, it's becoming 1 in 7 women, and that it's one of the fastest growing, cancers.
So what's the youngest one you treated for breast cancer?
I don't know what the youngest is, but I have this in mind, a 26-year-old pregnant patient that I treated just last week, and that was extremely heartbreaking. So that was, but I've seen a lot of patients under 30, a lot of under 30, a lot of people under 40, between 30 and 40. My tumor board presentation sometimes can be like 4 or 5 people under 40. It's sad.
My youngest one was 28 years old.
28.
Positive.
Yeah, that is very sad. 26, I guess, comes to mind for me, but yes.
More technical question. So you have the MRI equipment, of course, you do your MRI guided biopsies, because that's difficult. You know, we may have MRI, but we don't have the coil for breast. And then if you try to kick that up, even doing a biopsy, that'll have to be sent out. So sometimes that can be challenging in some of the smaller hospitals to get those biopsies done. Because most of these images, you can only see them on MRI, and that's the only way you can really catch them.
I completely understand. And I think if there's always what we call an MRI-directed ultrasound, if you have a breast fellowship trained radiologist that has been trained in looking at some of these MRI findings and correlating them with the ultrasound, that at times can be helpful if you run into an issue that you're describing. But sometimes you just can't. Ultrasound, it's like comparing apples to oranges. It's not the same way. The breast doesn't lay the same way. I know we are running into challenges because we're recommending more MRIs, yet we don't have the capacity, and we're in tertiary care center, right? We don't have enough magnets. We share the magnet with neuro. We share the magnet with MSK. We are 2 months out at scheduling a breast MRI biopsy, and that's extremely sad. Like,
Yeah, I can see if these bills get passed, that's going to be a problem.
yeah, there's just not enough magnets. There's just not enough trained people.
If I'm right on this, if we find 26 breast cancers in this group per 1,000, the number needed to treat would be about 39. And to put in perspective, the number needed to treat for community tomography, local CT of the chest is 320. For PAP, it's 80, about 80 or 90. For mammography, traditionally would be 125. You can make a pretty strong case from a public health point of view, if my back of the envelope calculations are right, that it's very affordable, and the downside is the hundreds of thousands of dollars it might take to treat those women.
Yes.
Treating 39, that's better than statins.
Yeah.
I mean, there's a number of interventions I could think of that would be,
Yeah.
I don't think it's out of the question that's unaffordable considering.
The argument is that we would save so much money. We would save so much money treating these cancers earlier. There'd be less costly treatments, less costly surgeries. There would be so much benefit. Somebody needs to have those numbers ready and prove that the benefit is much greater. But I think this bill will eventually pass. There was so much traction from the entire breast community. They had patient advocates, they had celebrity advocates, all over, the Congress when we do the Hill Walk. But we are all looking forward to this.
The funding is going to be challenging, though. All those magnets and the equipment to do it,
And that's where contrast-enhanced mammography is coming into play these days a lot, because it's almost equivalent to the sensitivity of MRI. So if MRI detects like 10 to 20 extra cancers per 1,000 in addition to mammogram, contrast-enhanced mammography is comparable. It's like up to 10 to 13 cancers per 1,000, and that's the next rank down. So I think a lot of centers have bought into that, and we have in Lexington several centers offering contrast-enhanced mammography. The only thing with it is, just like with contrast-enhanced everything, you have to have a physician on site, make sure there's no contrast reaction. You have to have trained technologists deliver the contrast. And I think there's no equipment, there's not a contrast-enhanced biopsy device. There isn't. So we still have to resort, if you find something, you still have to go back to ultrasound and find it, or maybe get an MRI. So there you are, splitting ways. So that's definitely a challenge. Well, I hope I shared that breast imaging, breast density matters, and for women in your lives and your patients or whatnot, pay attention to this letter, because most people just disregard the little handwriting, but it is us physicians that should inform the patients and have that open conversation about the supplemental screening. So, you're welcome. Thank you.